Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important session. Today, as you already know, we are going to discuss in details about the CSF examination, cerebrospinal fluid examination. Now, as you know that the cerebrospinal fluid examination is very important from the practical exam point of view as well as from the theoretical aspect. So, it is asked both in the practicals as well as in the theory. In the theory, it can be asked as a long answer question in the exam. Okay, so let us begin today's topic of discussion without wasting any more time. So, what are the things that we are going to read in today's topic? Let us see. So, first we are going to see the normal composition of the CSF and how do we collect the CSF. What are the indications of the lumbar puncture and what are the complications of the procedure? What are some of the contraindications? Then the lab examination. Okay, so this is the most important aspect. Most of the questions are mainly asked from this particular aspect. So, what are the things that we will discuss under the lab examination? We will discuss about the opening pressure, the gross appearance of the CSF, the cell count and the cell type. Now, this part is very important. Okay, why this part is very important? Because most of the students, they make a lot of mistakes and they do not know how to count the cells or how to do the cell count. Okay, so we are going to see in details and I am going to show lots of images. Okay, and I am going to make you understand about how to carry out the cell count, okay, in the CSFO. Then comes the chemical examination, the examination of protein, glucose, lactate and CSF enzymes. Then we have the microbiological examination, okay, and in the end we have a special investigations as well. So all these different lab examinations, they should be carried out and then you should correlate, okay, with the findings so as to come down to a proper meaningful diagnosis. Okay, so let us begin today's topic of discussion. So the CSF, if you see, CSF, it is a clear colorless fluid which is formed in the ventricles of the brain, mainly by the choroid plexus. So the rate of CSF production is around 25 ml per hour or 500 ml per day. It is reabsorbed into the blood via the arachnoid villi. So what is the composition of the normal CSF? You should know. Why you should know the composition of the normal CSF? Because if you don't know, then you are not going to be able to come to a definitive diagnosis if you don't know the correct values. So the total volume of the CSF, if you see, is 100 to 150 ml and around 10 to 60 ml in newborn. The opening pressure is 60 to 180 millimeters water or 10 to 100 millimeter in children and infants. The appearance of a normal CSF, it is clear and colorless with no clots. So there are no clots, okay, and the viscosity is like water. If you look at the total count, okay, if you see of the total leukocyte which is present in case of adults, the range is 0 to 5 cells per cubic millimeter. In infants, it is 0 to 30 cells per cubic millimeter. In 1 to 4 years, it is 0 to 20 and in 5 to 18, it is 0 to 10. So as the age is increasing, the amount of cells, they decrease, okay, and in adults, it is 0 to 5 cells per cubic millimeter. Erythrocytes, okay, none of the erythrocytes, they are not present, okay, so erythrocytes are not present in the CSF. The glucose, it is in the range of 45 to 80 milligrams per deciliter. Normally, the CSF glucose is 60% or 2/3 of the blood glucose level. The CSF to blood glucose ratio is less than 0.6. The proteins, if you see, the protein, the normal levels of CSF protein is 15 to 45 milligram per deciliter. Normal CSF proteins are 1% of the plasma proteins. The CSF lactate levels is 9 to 26 milligram per deciliter. Normally, oligoclonal bands, they are absent. So if you carry out the protein electrophoresis, okay, so oligoclonal bands, they are absent in normal CSF sample. They are present mainly in conditions which are associated with increased production of proteins, that is in case of multiple sclerosis, etc. Chloride levels are between 120 to 130 milliequivalents per liter. It is 20 milliequivalent per liter more than the serum level. Bilirubin, normally bilirubin, it is absent in a normal CSF sample. So these are the parameters and the composition of a normal CSF. Now collection of the CSF. So CSF is collected via lumbar puncture from the subarachnoid space. The site of lumbar puncture in case of adults, it is L3 to L4 or L4 L5. Why? Because the conus medullaris, the lower portion of the spinal cord, it is ending at L1 or L2. So that is why in adults it is L3 L4 or L4 L5 as the site for carrying out lumbar puncture. In infants and children it is L4 L5. Okay, it is L4 L5. Now lumbar puncture needle that is used, there are two important varieties. One is the atraumatic needle, another one is your standard bevel needle. Now we are not going into the details of the lumbar puncture and the procedure with which you are carrying out, although this can be asked in the exam, but it is asked in the instruments. Okay, it is not a part of the CSF examination, else the lecture will become very lengthy. Usually we are using a 20 to 22 gauge needle, okay, for carrying out lumbar puncture. I will show you with the help of diagram and explain the difference between atraumatic and standard bevel needle. Now once the CSF is collected, okay, it is collected in sterile plain plastic tubes, not in glass tubes. Why we don't collect in glass tubes? We will come to that later on. So they are collected in plain plastic tubes. So there are 4 tubes. The tube 1 where 1 ml is collected, okay, and the tube 1 is basically kept for the chemical examination, for estimation of glucose and protein, as well as for serology, The tube number 2, if you see, we collect 2 ml of sample in tube number 2. It is mainly done for microbiological purpose and for sensitivity test. Okay, so microbiological aspect means to do the staining, the gram staining, acid fast bacilli staining, India ink preparation done for the cryptococcus, then even for the culture studies. For example, for tuberculosis we are using the culture medium, that is the Lowenson-Jensen medium. Okay, for bacteria we are basically using the blood agar, chocolate agar, etc. For fungi we are using HDA, that is Sabarod's dextrose agar we are using for fungi. Then we are having the tube number 3 wherein 1 ml of sample is collected. Now this tube number 3 is very important for us pathologists because basically the hematological aspect, the cell count, cell type is mainly done from the tube 3. 1 ml is sent in tube 3, as well as we carry out the gross physical examination as well. And the tube 4 wherein another 1 ml is sent, it is kept for cytological evaluation or for special studies Okay. Okay, so now let us go ahead right now. Okay, so I am going to show you some images. So as I told you, if this is basically your L3, L4, L3, L4 and L5. Okay, so most importantly, if you see, the conus medullaris is ending here and these are the nerve roots. Okay, and this is where the subarachnoid space is, wherein your CSF is located. So we are most commonly, the site uses L4, L5. Okay, L4, L5 is the most commonly used site for carrying out the lumbar puncture, okay, or for the tapping. So if you see this diagram, as you can see, the conus medullaris is ending over here at L2. So L3, L4, this space, and L4, L5, this space is more important, or most commonly it is done to be on the safer side between L4, L5. Okay, as you can see, this needle is being passed and it is entering the subarachnoid space, and from there the CSF is basically collected. Okay, so this is the basic site. Site is very commonly asked. Now remember, whenever you are given a lumbar puncture needle, always remember, don't make a mistake. See the one part which is getting inserted inside, that is the stillet. Okay, and inside which it is introducing, this is called as a spinal needle. So you can see this is the spinal needle and this is the stillet. Please do not say the opposite. The stillet is always going inside the spinal needle. So there are two important parts for a LP needle, that is the stillet is there and a spinal needle is there. Okay. Now I told you that there are two important kinds of needle. Okay, one is the standard needle. Now the standard has the usual beveling. Okay, so they are having bevel. Bevel means it is like this. The tip is something like this. Okay, so basically there is a beveling over here. As we can see, there is a beveling, standard bevel needle. Now this needle, if you see, it is most commonly used everywhere, and this is the needle which is also having majority of the complications. There will be more trauma, more CSF leakage, so more headache will be there, or most post procedure complications are far more common with the standard needle. Whereas there is something called as atraumatic needle. As you can see in the atraumatic needle, the tips, they are pencil point tip. Okay, so they are pencil point tip, and over here if you see, there is no beveling and the cut is basically little above the point of insertion. So this atraumatic needle, as the name suggests, it is atraumatic, causes less amount of injury and less amount of CSF is withdrawn, so the leakage is less, so the complications are also less as compared to the atraumatic needle. These needle are not very commonly used, in comparison with the standard needle. Okay, so again I am telling you, these are very basic stuff, so we are not going into the details of each and everything. Now, as I told you, the normal appearance of the CSF, if you see, it is basically clear like a water. Okay, remember, this is xanthochromia. More in details about that we are going to discuss when we discuss about the gross appearance. Okay, so the amount of CSF that is collected is around 3 to 5 ml. Up to 25 to 30 ml CSF can be safely withdrawn in an adult. Okay, so with this we have completed the collection part, as well as we have collected basically we have read about the normal composition of the CSF. Now we are going to understand about the indications for doing or carrying out the lumbar puncture. So most importantly, the examination of the CSF is done mainly for the diagnosis of suspected cases of CNS infections like meningitis, encephalitis, or to see the meningeal involvement by leukemia or malignancy, or if there is any subarachnoid hemorrhage. If CT scan is not available, then lumbar puncture has to be done for the detection of subarachnoid hemorrhage, or for detection of inflammatory diseases like multiple sclerosis or GB syndrome or neoplasms of the CNS. Now, indications A, B, C, if you see, these are emergency indications of carrying out an emergency lumbar puncture. So this is the first important indication for diagnosis of different conditions. Second is to reduce the CSF pressure in a case of benign intracranial hypertension in conditions like the pseudotumor cerebri, or for administration of medications like anesthetic medications, we are giving the spinal anesthesia, okay, or antibiotic administration or anti-cancer drugs. So when you have to give intrathecal administration of drugs, introduction, or it is used for introduction of radiographic contrast media for myelography. So these are the very important 4 important indications of carrying out a lumbar puncture. Coming to the complications of lumbar puncture. So post-puncture headache, most common side effect is the post-puncture headache, and it occurs due to the leakage of the CSF from the puncture site at a rate faster than the rate of CSF production. So what is and how you can prevent this post-puncture headache? You should use a smaller bore needle. So you go for a higher size, 22 gauge or smaller, keeping the patient flat after the procedure for 2 to 3 hours and replacing the stellate before you withdraw the needle. You should always replace the stellate so as to minimize the leakage of the CSF. Then the second important complication is you might introduce infection if aseptic precautions are not taken. Subdural hematoma in patients who are having a bleeding diastasis. Failure to obtain CSF, very importantly, you can get a dry tap, and more commonly you can get the dry tap when you are using an atraumatic needle. Herniation of the brain. Now for example, if the pressure is very high and if you have taken out a lot of CSF, then it might lead to herniation of the brain, especially the herniation and affecting the brain stem, leading to cardiorespiratory failure. It can also lead to subarachnoid, subdural or epidural bleeding of the spine can occur as well, okay, in case there is any kind of bleeding diastasis. So what are the contraindications of the lumbar puncture? Raised intracranial pressure due to space occupying lesion, example brain abscess, subdural hematoma or a posterior fossa tumor, because if you do in such a compromised condition, you might actually precipitate brainstem herniation. Or if the patient is having any kind of cardiorespiratory compromise, or the patient has a bleeding diastasis which has not been corrected, local infection at the site of lumbar puncture if it is there, and fifth and most important point, actually I forgot to add, if the patient doesn't give consent, so that is also a contraindication, you will not do the procedure. Now we come to the very important aspect of the CSF examination, that is the laboratory examination of the CSF. So after collection, the CSF samples, they should be sent to the lab immediately and examined without delay. Why? Because the cells, they disintegrate rapidly and there is a reduction of the glucose occurs because of glycolysis. So If you delay the process, you might get a falsely low cell count and you might get a falsely low level of the blood of the CSF glucose. So that is the reason the standard time for examination is within 1 hour of collection. Remember, glass tube should not be used for collecting the CSF since the cell adhere to the glass and can give a falsely reduced cell count. Specimen for bacterial culture should not be refrigerated since fastidious organisms do not survive in the cold temperature. So what are the different components of the CSF examination? Very importantly, we are having the opening pressure, the gross appearance, the total and the differential leukocyte count, that is the cell count and the cell type. Then we have the chemical examination, microbiological examination and special investigation. So we are going to see each and every aspect of the CSF examination, starting with the opening pressure. So the opening pressure is measured by attaching the manometer to the hub of the spinal needle. Normal CSF opening pressure is 60 to 180 millimeter water in adults and 10 to 100 millimeter water in children who are less than 8 years of age. Now the CSF pressure, if you see, the CSF pressure can be increased in conditions when you have a tense or anxious patient, when the intracranial mass lesion is present like any neoplasm, abscess or hemorrhage is there, in conditions of meningitis, cerebral edema, subarachnoid hemorrhage, CCF, congestive cardiac failure, or in conditions of benign intracranial hypertension, for example pseudotumor cerebri. Now the CSF pressure can be reduced or decreased as well in conditions when there is leakage of the spinal fluid following trauma or previous lumbar puncture, or there is a complete spinal block due to any kind of tumor, abscess or adhesions. Okay, so these are the conditions where the CSF pressure can be increased or decreased. Okay, if the CSF opening pressure is more than 200 millimeter, then no more than 1 to 2 ml should be removed. Why? Because you might precipitate brainstem herniation. Okay. Coming to the second important aspect, that is the gross appearance. Very importantly, normal CSF is completely clear and colorless, just like the distilled water, and does not clot. Abnormal CSF, they will show turbidity, or they will be blood mixed, or they will show xanthochromia, or they will be viscous, or there might be clot formation. Clot formation always indicates an increased protein amount. Now very importantly, if you look at the turbidity, now when the CSF is turbid, it basically appears turbid because of an increased amount of WBCs and RBCs. So when the cell count is very high, you will see a turbid or a cloudy CSF, where there is a presence of microorganism, or when there is raised amount of proteins. Okay, where there is raised amount of proteins. In such conditions, the CSF will be turbid or cloudy. So let me just show you the different kinds of appearance. So this is just a basic appearance. I am going to show you the real pictures as well. Okay, so stay tuned. So very importantly, if you see number A, this is the normal CSF which is clear and transparent. Then the CSF might be bloody as well. So this bloody CSF can have two reasons. Either it might be because of a subarachnoid hemorrhage, or it might be because of the trauma or traumatic CSF when there is some kind of trauma at the time of doing the procedure. So how can you differentiate between the two? So a bloody CSF, it should be centrifuged. After centrifugation, if the supernatant becomes clear, okay, if there is a clear supernatant, then it is because of trauma. But if the supernatant is yellowish, okay, then it is basically indicative of subarachnoid hemorrhage, and yellowish supernatant is called as a xanthochromia. Okay, and lastly we can have a turbid CSF as well. So I've already spoken about the causes of a turbid CSF, because of an increased WBC or RBC count, because of microorganisms, and because of raised proteins. Now blood mixed CSF, as I already told you, it can either be because of a traumatic tap, or it can be because of subarachnoid hemorrhage. Remember one thing, that xanthochromia, it always develops after 12 hours of the subarachnoid hemorrhage and not before that. So grossly, how do you differentiate? What are the points of differentiation between the traumatic tap and the subarachnoid hemorrhage? So grossly, if you see, the blood is more in the initial tubes, that is if it is because of traumatic tap, and blood is uniformly present in all the tubes in case of subarachnoid hemorrhage. Blood clots on standing in case of a traumatic tap, but in case of subarachnoid hemorrhage, the blood does not clot. After centrifugation, the supernatant is clear in case of traumatic tap, whereas it is pink or yellow. Okay, pink or yellow. Initially, it can be pink in case of subarachnoid hemorrhage because of the release of oxyhemoglobin, which later on converts to bilirubin by the macrophages and gets a yellow color. This yellowish color of the supernatant is called as xanthochromia. Microscopic examination, if you do, there is a progressive decrease in the RBC count in the later tubes, and whereas in case of subarachnoid hemorrhage, the RBC count is uniform in all the tubes, hemosiderin-laden macrophages are present. Latex agglutination test is negative in case of your traumatic tap, whereas it is positive in subarachnoid hemorrhage. The CSF fluid pressure is normal in case of your traumatic tap, whereas the pressure is increased in subarachnoid hemorrhage. The CSF fluid protein is again normal in case of your traumatic tap, whereas it is increased in case of subarachnoid hemorrhage. Absorbance of bilirubin and net oxyhemoglobin is normal, okay, whereas over here it is increased, and basically this is seen 12 hours after the development of symptoms, okay. So this is how you differentiate a bloody CSF, okay, and how you differentiate between a traumatic tap versus the subarachnoid hemorrhage. Now, what is xanthochromia? Xanthochromia is defined as the yellowish discoloration of the CSF. That is what is called as a xanthochromia. So what are the causes of xanthochromia? Again, this is a very important viva question in the exams, okay. So what are these causes of xanthochromia? Subarachnoid hemorrhage. Most common cause of subarachnoid hemorrhage is because of trauma. Second most common cause is berry aneurysm. So subarachnoid hemorrhage, 12 hours after the bleeding episode, there will be xanthochromia, which is going to peak in 2 to 4 days and disappears by 2 weeks. Jaundice. Jaundice can be a cause of xanthochromia when the serum bilirubin level is more than 6 mg per deciliter, or when the CSF protein is more than 150 mg per deciliter, you can develop xanthochromia. So what are the causes of xanthochromia? It should be very, very clear to you. So how do you detect xanthochromia? So one I already showed you before. You can carry out a visual inspection of the supernatant, or you can go for spectrophotometry. So what are the other abnormal CSF colors? So pink color is seen when RBC lyses and there is release of oxyhemoglobin. So initially after the subarachnoid hemorrhage, the color of the supernatant after centrifugation of the CSF can be pink initially because of the release of oxyhemoglobin. So on prolonged standing, the macrophages are going to break down this oxyhemoglobin into the bilirubin, which is going to give the yellow color, and that is responsible for the xanthochromia. Then it might be brownish CSF might be there because of meningeal metastatic melanoma, or can be orange color because of high carotene ingestion. Sometimes it can be reddish orange in color as well. It is basically when you ingest certain drugs like rifampicin. Excuse me. So let us see. This is the normal CSF, clear, watery. This is xanthochromia. You can see after centrifugation, this has become yellowish in color. Okay. Now basically, if you see, this is the traumatic tap. This is the traumatic tap. Why am I saying traumatic? Because when the collection was done in the subsequent tubes, the red color is fading. It is becoming less. Okay, so that is why this is a traumatic tap. Or bloody CSF, it looks like this. Now this, as you can appreciate over here, this is cloudy, number one. Number two, it is turbid. And turbid is basically indicative of some kind of infection or meningitis. They have increased RBC, increased WBC count is there. Increased amount of WBC count, increased protein is there. There is increased amount of proteins over here. And if you go for the gram staining or something like that, you can isolate certain organisms. Okay. Red orange, as I already told you, after ingestion of certain drugs like rifampicin. Third important gross appearance is the formation of clot. Now clot formation, okay, initially there is pellicle formation, that is a thin membrane or scum on the surface of CSF, which later on goes on to form a clot. Now clot formation, if you see, it indicates an increased amount of proteins more than 150 mg per deciliter. And what are the conditions where you will see? In case of TB meningitis, there is a cobweb like clot formation because of an increased amount of fibrinogen. And this clot contains mycobacteria, which can be used to make a smear for AFB, and we can use it for culture in LJ medium, okay, to isolate the organism. Then in case of purulent meningitis, there will be increased amount of protein, so clot formation can be there. In conditions of spinal block, there can be complete clotting of the CSF, or in case of traumatic lumbar puncture as well, there can be clot formation as well. The fourth important point is a thick viscous CSF can be seen. A thick viscous CSF is most importantly seen in conditions of cryptococcal meningitis, in meningeal metastatic mucinous adenocarcinoma, and in case of severe meningitis. So with this, we have completed the gross appearance of the CSF in details. Now we are going to discuss very important aspect, that is the cell counts in the CSF. Okay, so over here in the cell count, we are going to see the cell count and the cell type as well. So first we will discuss about the total leukocyte count. So if you see the total leukocyte count, it is the cell count in the CSF. It is done manually on undiluted sample in a counting chamber. Most commonly we are using the improved Newbar's chamber. Okay, WHO says that you should use the Fuchs Rosenthal chamber because they have more depth. Okay, and nowadays in many places you are having automated counters as well. They give a very accurate count. But most commonly in our setup, we are using the improved Newbar's chamber only. So an increase in the cell count in the CSF, it is called as pleocytosis. It is a very important viva question for your exam. It is essential to do microscopic examination of all the CSF samples. Okay, since WBC count up to 200 per cubic millimeter and RBC count up to 400 per cubic millimeter are associated with clear appearance of CSF. So this is very important, that if it is clear, everything is clear, then why you want to do the count? So the examiner might ask you this question. So the answer to that is that even if the CSF has a very clear appearance, okay, so it is yet essential to do the microscopic examination, because WBC count up to 200 per cubic millimeter and RBC count up to 400 per cubic millimeter are associated with a clear appearance of CSF. So that is why microscopic examination is a must. The cell count should be done as soon as possible after collection of CSF, within 1 hour actually, since the cellular disintegration occurs rapidly. Example, at room temperature, granulocytes, they start to disintegrate within an hour of collection of CSF. The cells strongly adhere to the glass tubes. Therefore, sample for CSF analysis should be collected in plastic tubes and not in the glass tubes. No dilution of CSF is usually required. A diluent should be used only if the CSF is turbid or cloudy and likely to contain an increased amount of leukocytes. So what you have to do, the next step, you should mix the CSF sample carefully. So after you mix the CSF sample, or just shake the sample, if the sample is clear, you do not need any kind of dilution of the CSF. But if the sample is cloudy and turbid, then you have to dilute the sample. Okay, you have to dilute the sample only when it is cloudy or turbid, because cloudy and turbid sample indicate that there is an increased total count. Okay, so because if the count is very high, you might not be able to count the cells individually and you have to dilute it initially. So the amount of dilution depends on the amount of turbidity or cloudiness that is expected or that is seen. Normally, for example, if it is slight hazy, we can use 1:20 dilution is made. So how is the dilution made? That around 0.05 ml of CSF, you add 0.9 ml of Turk solution, which contains glacial acetic acid, methylene blue and distilled water. Okay, so Turk solution is added, which contains glacial acetic acid, methylene blue and distilled water. So 1:20 dilution means what you are doing over here, you are adding one part of the CSF and to that you are adding 19 parts of the diluting fluid. Okay, so this is how you make the dilution. So over here the one part is 0.05 ml and 0.95 ml, that is a Turk solution. So you are making a 1:20 dilution. This when added together, okay, this when added together should come up to 20. So this is the dilution factor, that is the 20. Okay, the counting chamber is covered with a cover slip. Okay, the counting chamber is filled with the fluid and allowed to stand for 2 minutes for the cells to settle. Now this is the improved Newbar's chamber. So you can see that on the outer aspect there are 4 large WBC chambers wherein we are counting the WBC, and there is a central RBC chamber wherein you are counting the RBCs. Now I am not going into the details of the Newbar's chamber. I have already explained in details about the Newbar's chamber in the efficient cytology lecture. Over here I am just going to the very important basic fact. So where the CSF for the CSF counting, we have to do the total count in this 4 large WBC squares. Okay, now very importantly, if you look at, if we take an individual square, this is the individual square. If you see the net length and breadth, if you see, this is for example 3 millimeter and each one of this square is 1, 1 and this is 1. Similarly, over here if you look at the breadth, okay, it's like a square. It is totally 3 mm. So each individual square is 1 mm. This is again 1 mm. This is 1 mm. And what is the depth? The depth is basically 0.1 millimeter is the depth. So for example, we have to do the counting in the 4 large WBC square. So for example, in this 4 square, 1, 2, 3 and 4, you have counted, for example, total number of cells counted is X, okay? You have counted X number of cells. So, and you have done the counting under the high power, under 40X, you have done the counting. So the total number of cells counted is X, okay? So what is the volume of each large square? It is the length into breadth into the depth. So the length of each square is 1 mm, breadth is 1 mm and the depth is 0.1. So the total volume of each large square is 0.1 millimeter cube. So the total volume of all the 4 large squares, if you see, is 4 times 0.1, that is 0.4 millimeter cube. So right now, if 0.4 millimeter cube is containing X number of cells, so in 1 millimeter cube, how many cells are present? It is X divided by 0.4. Okay, it is X divided by 0.4. That is going to give you the total number of cells which is present per millimeter cube. Now, this is the case when you have not used the diluting factor. But in case you are using the diluting factor, in that case you have to multiply X by 0.4 into the diluting factor. Okay, so this is very important. So in normal conditions you can see X by 0.4 is nothing but it is 2.5X. So normally if you have not used any diluting factor, then whatever cells you have counted in the 4 large squares, you just multiply by 2.5 into X to get the answer as how much per millimeter cube. But if you have used any diluting factor, then along with X you have to multiply with the diluting factor as well. Okay, so this is how the formula has been derived and you do not have to mug up the formula. Okay, just remember this. As I told you, other chamber that is preferred by WHO because they are having a more depth is the Fuchs-Rosenthal chamber. I hope it is very crystal clear how to do the counting. Very important, the same method is also applied for counting any, even in case of semen analysis, even in case of ascitic fluid, pleural fluid, any other kind of fluid we are doing or we are counting in the same manner only. Okay, so there is no change whatsoever. Okay, it is just that we are using diluting factor. In that case, we have to multiply by diluting factor. So over here, the diluting factor was 20. So you should multiply by 20, X by 0.4 into diluting factor, that is 20. If diluting factor is not used, usually in 95% cases when you are examining the CSF, you are not using the diluting factor. So the answer is X divided by 0.4. So for example, in all these 4 chambers, you have counted, for example, you have basically counted 2, you have counted 0, you have counted 0, you have counted 1. So total you have counted 3. Okay, so 3 divided by 0.4 is the total number of cells per cubic millimeter. That is equal to, okay, to 2 are 4, to 5 are 10. Okay, it is 15 by 2, approximately 7.5 cells per cubic millimeter. Okay, around 7 to 8 cells per cubic millimeter. This should be your answer. Okay, now if you have used some kind of dilution and after that you are getting, then 7.5 should be multiplied by 20. Depending, if you have used 1:20 dilution, so into 20. If you have used 1:100, so into 100. So it depends on that. Okay. Now, what are the causes of increased cell count in the CSF? Okay, so normal CSF as an adults, we know they are having less than 5 leukocytes per cubic millimeter, and most of the cells normally they are mononuclear cells, so they are monocytes and lymphocytes. Okay, so in which conditions does the cell count increase? Normally they are increasing in conditions of meningitis and other infections of CNS, in conditions of intracranial hemorrhage, or meningeal infiltration by malignancy, or conditions of multiple sclerosis or repeated lumbar punctures, or during injection of foreign substances in the subarachnoid space. So with this we have completed the causes of increased cell count and we have completed how you should carry out a total cell counting. Okay. Now the differential leukocyte count. So in normal adults, the normal DLC, if you see, 70% is lymphocytes, 30% is monocytes. So basically 100% of the cells, they are mononuclear cells. Okay. In young children, you have a higher proportion of monocytes to the tune of 70%. Now very importantly, if the cellularity is less, okay, In that case, you carry out centrifugation of the sample and the concentrated cells, they are smeared on the slide. Okay, but if the cellularity is very high, okay, then direct smears from uncentrifuged samples are made, and in either condition they are smeared and a smear is made. The smear is stained with one of the Romanovsky stain like Leishman stain, Leishman GMs, and then they are examined under the microscope, okay, for identification. So the organisms which are causing meningitis, okay, so let us see, we are having bacterial, viral, fungal and parasitic. So under the bacterial, those affecting the neonates includes the group B streptococcus, which is most common, followed by gram-negative organism like E. coli and Listeria monocytogenes. In children, it is Neisseria meningitidis and Streptococcus pneumonia. In adults, it is Streptococcus pneumonia and Mycobacterial tuberculosis. Now, viral causes include Coxsackie virus as the most common cause, followed by mumps, herpes simplex, varicella and HIV. Fungal causes include Cryptococcus neoformans, Candida, Mucor aspergillus. Parasitic causes include Entamoeba histolytica and Naegleria fowleri. So these are some of the causative agents of meningitis. Now the differential cell count in the CSF, if you see, predominantly neutrophils if you are seeing, then it is suggestive of meningitis, mainly bacterial, or it is suggestive of subarachnoid hemorrhage, repeated lumbar puncture, or okay, in very early stages of viral TB, fungal infections, or when you have administered any contrast media or anti-cancer drug. Now, predominantly lymphocytes are seen in meningitis, that is viral meningitis, tubercular meningitis and fungal meningitis, or in those bacterial meningitis which are incompletely treated, or in conditions of cysticercosis or toxoplasmosis, or in multiple sclerosis. Mixed cell pattern, if you see, mixed cell pattern is seen in TB, fungal and chronic bacterial meningitis. So let us see how the cells looks in the Leishman GM stain. So as you can see over here, these are filled with the neutrophils. So this is the purulent bacterial meningitis. Okay, then how the normal monocytes they look like and how the lymphocytes look like. So this is how the monocytes look like normally, and this is how the lymphocytes look like in the CSF. Now CSF analysis is also done to see any kind of CNS relapse in children treated with treated for the leukemias. So you can see the presence of the blast in the CSF. So this is basically indicative of the CNS relapse. Then sometimes any metastatic disease, for example metastatic breast disease, okay, breast carcinoma might metastasize to the brain, and in that situation they are looking like this. Now how does the cell look like normally in the Newbar's chamber? So you can see I have highlighted some cells in red and I have highlighted some cells in yellow. So you can see those cells, you can see now these are 100% mononuclear cells. These are dull looking cells. These are basically lymphocytes. Okay, it can be mononuclear cells or it can be monocytes as well. So basically these dull looking cells which are non-refractile when you change the stage, they are mainly the important mononuclear cells. Mostly they are lymphocytes or monocytes. Okay, whereas if you see certain cells, as you can see in yellow, now over here you can see these cells, these are biconcave. So they are like this and they have another round like this. So they are biconcave, and if you move the stage, they are refractile as well. So what are these? These are actually the RBCs. This is in reality how the cells looks like when you examine under the Newbar's chamber, how the cells looks like. Okay, this is one of the chamber of the Newbar. So these are how the RBCs look like, and this is how the lymphocytes look like. If you see over here, okay, this is one cell. I don't know if you can make out, there is one and there is another. So this is basically a neutrophil. This is how a polymorph looks like. So basically you are not supposed to differentiate or to carry out a DLC when you are examining under the Newbar's chamber. In the Newbar's chamber, you are only doing the cell count but from the morphology, you are able to differentiate the cells. Okay, how you are differentiating the cells under the Newbar's chamber? This is one vague method of differentiation. You have to carry out the Romanovsky stain like this, and you have to examine, because under the Romanovsky stain, to identify the different cells, they are more easy because they are stained. Okay, but under the Newbar's chamber, how you do the cell count, where you are doing the cell count. Okay, so it is very, very important. Okay, and remember, when you are doing the cell count, you should not count the RBCs. You should always just count the leukocyte, because you are carrying out a WBC count over here. Okay, so this particular photograph that you see, this is basically that of an ascitic fluid. But what I wanted to show you over here, that how the cells looks like under the Newbar's chamber, when you are examining in the Newbar's chamber. Okay, so this is how the neutrophil look, this is how the mononuclear cell lymphocyte looks, and this is how the RBCs look like. Okay, just for differentiation. Okay. So predominantly eosinophils, they are seen where? They are seen in the parasitic or fungal infections, okay, or any reaction to the foreign material is there, okay, any shunts. So basically, in short, remember, in case of bacterial infection, you will have increased neutrophils. In viral infection, in the first 24-hour neutrophil is there, that is followed by change to lymphocytes in next 2 to 3 days. And in fungal infection, if you see the mixed pattern with predominance of lymphocytes and monocytes, okay. So with this, we have completed in details the total cell count and the differential leukocyte count. Okay. Now in the next part, we are going to start with the chemical examination of the CSF.